Hi, everyone, and welcome back to From Print to Pod. With us today is Dr. Janice Makala, who is going to talk about her article called Beyond the Pain Scale, Addressing the Emotional Side of Suffering. Dr. Makala, would you introduce yourself?
I'm Dr. Janice Makala. I am a physician who's done hospice palliative care for 20 years. I've also am a geriatrician. And recently, I've also expanded into the cannabis field, learning more about cannabis medicine. And so, yeah, thank you for having me. It's great to be here.
Of course. Let's get right to the questions. So, you opened your article with a stark contrast between Marines and hospice patients. Why was it important to highlight those differing perspectives on pain?
It wasn't just hospice patients as a whole, because it was really the contrast between stoicism versus actual people who feel suffering. And it's this idea that pain and suffering are separate from each other, that you can modulate suffering. And so someone with a great deal of stoicism, like a Marine, can say, it's just pain. But then someone who has a lot of existential problems dealing with the end of life or whatnot, may experience that same pain in a very different way. And so it's really just this idea that pain doesn't necessarily equate to suffering. And so, and there's a reason, and I kind of get into that in the article.
Thank you for that. You mentioned total pain as including spiritual or emotional suffering. How do you approach this concept in your clinical practice, and what signs do you look for beyond the numeric pain scale?
Right. So total pain. Um, this, I believe, is actually from Cicely Saunders, the woman who started hospice, the Dr. Saunders. And she described this idea that pain wasn't just a number, it wasn't just a physical reaction, but that there was total pain, and that existential, experience was part of it. At the end of life, people are dealing with, a lot of emotional issues. Now, some people, they don't. They have it all under control and it's good. But there are a lot of people who are dealing with these issues. Or maybe they have a pre-existing psychiatric thing, depression, whatnot. And that then amplifies their sensation of pain. And so total pain, that is why all hospices have to have a social worker and a chaplain. You need to address the social issues that might be leading to this pain, and you need to address the spiritual issues that are leading to this pain. So that is what we're talking about when we say total pain.
Thank you. Can you elaborate on how the neurological pathways of A delta and C fibers shape not just the sensation of pain, but our emotional response to it?
Sure. So we have a couple different fibers that feel pain. One of them's the A delta. That's sort of the sharp pain when you burn your finger on a stove and you go, oh, that hurts. That's A delta. And it actually creates a reflex right up to the spine that says, oh, hey, move your finger from that. That hurts. Before your brain even processes it. Then it goes up to the brain. And then the brain's able to say, sharp pain, sharp pain, tip of finger, and describe the intensity, moderate to severe, da da da, right? And then the frontal lobe processes it and says, oh, let's put it under some cold water. Meanwhile, as you're walking over to the sink, it starts to throb. That throbbing is actually C fibers. They're very inflammation based. So that inflammation of that injury creates C fiber pain. It's not very great at localizing. That's why your entire finger hurts, or at least the tip, where you burned it. But beyond the area the burn starts to hurt. And that is C fiber pain. It doesn't localize well. It kind of throbs and aches. And that particularly goes up to the two tracks of the brain. The paleospinal thalamic tract and the archaeospinal thalamic tract are these evolutionarily older pathways, in the fact that they're in, almost every animal, and they go up to the emotional part of the brain and some other areas, of course, but the emotional part of the brain. And that's to kind of, it gives us an emotional response to pain, which makes sense. Because, if you're a mouse and you just got your tail swiped by a cat, you now know to fear that cat. That emotion of fear, that thing that causes you pain is real. And so there's that, you know, oh, I hurt myself and to describe it. Then there's the mommy kiss it. This is why mommy kisses feel better. This is why swearing actually makes people tolerate pain better. These kind of emotional releases um, can help with pain or make it worse. If
Thank you.
there's, yeah.
Thank you for that. And I will interject here to just say that Dr. Makala is going to join our faculty lineup for the upcoming SoMe Docs Pain Conference. That's all online. So definitely check that out. I'm so excited. Her talk is titled Cannabis, Cannabinoids, and Pain. And she will examine the science behind cannabis and pain, exploring the endocannabinoid system and evidence about THC, CBD, and other cannabinoids' effect on pain modulation. So we can't wait for that. Okay, next question. You wrote that opioids often fail to address the emotional side of pain. In your experience, how does cannabis complement or enhance what opioids cannot achieve?
Well, you know, I think you see a lot of people who will say cannabis, oh my gosh, it's so great. And there are studies to show that it does diminish the amount of opioids that a person needs if they use cannabis. And, but I will say from seeing people who use cannabis, it can't replace opioids. Opioids do play a role. They're a different point in the pathway. Your brain actually has an inhibitory pathway to block pain. And the cannabis, the CB1 receptor, actually starts that pathway down. Um, your body's natural endocannabinoids do that if you don't have cannabis, but it will start that pathway. And then opioids modulate on a different point in the pathway. So the two can work together. As far as opioids, yeah, I see a situation a lot where I can bring their pain down. They come there like, it's 15 out of 10, doctor. I'm like, okay, let me give you some. I give them some strong opioids. The next day, it's 5 out of 10, doctor. And I'm like, okay, but it's better, right? No, doc, it's still bad. I'm like, okay. You see that disconnect, right? That number has gone down, but they're still suffering. Um, I see a lot of that. And, usually that's a clue. We need to get the social worker chaplain. But that suffering kind of creates that sense, doesn't respond as well to opioids. And I think because cannabis does have a little bit more of a central effect in terms of the emotional areas. You have it in the amygdala, cannabis receptors, CB1 receptors, that I think you get a sensation where people just feel a little bit better. That emotional response is just a little bit more chill, that kind of chill that people get, right? And so I think those two can work very well together in the hospice world, where people have a lot of pain, and then the cannabis can help with the emotions. Now, cannabis does help also with the physical part of the pain, as I've described, but I think the second part it does is you start caring a little bit less about the pain.
Thank you for that. Here's the next question. There's still some stigma around using cannabis in clinical settings. What do you think is the biggest barrier to wider adoption in hospice or palliative care?
Number one, the legal status of cannabis federally. Hospice is medical. I've actually, at my most recent hospice I'm working at, mentioned, I'm like, we could really kind of put a market for ourselves by saying we're cannabis friendly, right? And he's like, yeah, except for Medicare. We're paid for by Medicare. It's federal. We can't, we stand to get in some trouble with the feds. And I think that's a lot of it. In fact, the endocannabinoid system that I've talked about, that is our body's natural system that cannabis works on. But it's not just pain, it's metabolism. Um, there's a cardiac, there's some lung, it affects a variety of different systems in our body. Like I said, some of the more notable ones are the metabolism. And it doesn't have, it's not taught in med schools. We all had to learn the angiotensin-renin system in med school, but no one heard anything about the endocannabinoid system. And so I think that's the second thing is that knowledge about what this is, that this isn't, uh, you know, this is a medicine that's acting on a natural part of our body, just like ACE inhibitors, right, on the angiotensin system. And so I think I think education, but I think the legal status has really scared people away. I have colleagues who feel that the endocannabinoid system isn't taught because it has the word cannabis in it. And even that has scared people away.
Thank you for that. Next question is, what role do chaplains or social workers play once you've identified suffering beyond the physical? How does interdisciplinary care impact outcomes in hospice settings?
So that's huge. We have to have bi-weekly, every 2 weeks, bi-weekly. Yeah. We have to have, we have to have a meeting every 2 weeks where we discuss the patients. Um, with the social worker, with the chaplain, there are mandatory parts of the team because it's so important. And it is important because, as again, that emotional, a lot of the times that distress they have. I mean, so take, for example, a mother with breast cancer in her 30s dying, right? As sometimes tragically happens, and their children are just toddlers. That fear of what's going to happen to my kids um, is huge. And so that social worker has to help them. What can we do? Make sure that they're taken care of after you're gone. Or someone who's lived maybe a little bit of a rough life. I'm going to go see God now. Oh my gosh, what does that mean? The chaplain, right? But spiritual issues, did I live a good life? Is God going to be happy with me? Stuff like that. The chaplain can help. But they often will work together on different things, especially when things about legacy and leaving a legacy for your family or something like that. So it's huge because one, it helps with pain, but two, it helps with suffering and distress, and it also helps the family too, though, right? Because a lot of the things they deal with are social dynamics. The one family member who's not ready for grandma to die and wants them all, is making a fuss, or when everyone else has decided and grandma has decided on hospice. Um, those are things that can have ripple effects that affect whether someone maybe in the family gets depression afterwards, has pathological grieving. So the social worker and the chaplain are huge in their role at hospice.
Thank you for that. The final question is, if there's one misconception you wish more people, especially clinicians, understood about pain versus suffering, what would it be?
You can't just throw opioids at it. We have this whole opioid epidemic right now. And I think people are getting at, right, that, oh my gosh, yeah, we had this opioid epidemic. And that there's more you can do to address the suffering beyond just opioids. That, a lot of times people who have depression can experience pain worse, for example, outside of even hospice, right? There's study after study show that a person who's depressed feels pain more. And if you are someone who holds to the neuroreceptor argument of depression, that the serotonin is low, the norepinephrine is low, um, that actually makes a lot of sense because remember that inhibitory pathway I was saying? Serotonin and norepinephrine are in that pathway too. So perhaps if someone genetically has a decreased amount of serotonin and norepinephrine that makes them prone to depression, it would also make that pathway worse for pain. That inhibitory pathway isn't going to be working as well because you need serotonin and norepinephrine in that pathway. A little geeky there, but it's this idea that no, it's not just all in your head. If you're depressed and you're feeling pain more, you probably are. And so you need to address other issues. You need to look at depression. You need to look at why is this pain causing them so much trouble, you know, um, and help your patients kind of figure that out, that pain isn't just throw pills at it. I mean, and that's the beauty of like a good pain clinician. Now, that's not the same as hospice and palliative. I tend to deal with people more with life-limiting illnesses or cancer-based pain, whereas a pain specialist is going to be more of your chronic back pain or your injury pain, chronic pain, that type of thing. And a lot of good pain specialists now incorporate um, a lot more uh, support for people dealing with the emotional or psychological aspects of pain in addition to what they do.
Thank you so much for that. There you have it, everyone. Dr. Makala, she wrote Beyond the Pain Scale, Addressing the Emotional Side of Suffering. You can read that on doctorsonsocialmedia.com/magazine. Dr. Makala, thank you so much for joining us.
Thank you. I appreciate it. Great talking to you.